we're extremely lucky to have with us Dr. David Goff Jr., who is Director of the Division of Cardiovascular Sciences at the National Heart, Lung, and Blood Institute. That's the heart-focused, cardiac-focused institute at the National Institutes of Health. The NIH has been very good to NPF over the last several years, and we've had several institute directors and deputy directors come and present on our various health topics. Dr. Goff previously was Dean and Professor of Epidemiology at the Colorado School of Public Health. He was also chair of the Department of Epidemiology and Prevention at the Wake Forest School of Medicine. He's also been involved with all the major heart-focused associations, and he is going to talk about federal research priorities, a strategic plan for the NHLBI, and kind of what some of the gaps in knowledge are out there, and what the federal research efforts NHLBI and their grantees are doing about it. It's 10:30 right now. We have him till 11:45. He'll present. I have plenty of time for questions, and I'll turn it over to Dr. Goff.
Thanks, Chris. Well, good morning, everybody. Try that again. Good morning, everybody. Good morning. All right, that's a little better. You've got a really great lineup here. I was looking at the speakers who are going to be coming to talk with you during your time here, and so you're going to get a lot of great information about cardiovascular health and how we're working to prevent cardiovascular disease, leading cause of death in the country and the world. So I'm really privileged to be part of that and to be talking with you today a little bit about the mission and vision of the Institute. So I'd like to start by giving you greetings from our director, Dr. Gary Gibbons, my boss, who sends his greetings to all of you. It's a real privilege to work at NIH and to work at the National Heart, Lung, and Blood Institute, where we try to do what we can to nurture the best science and to turn that science into improved health at the population level. So the Heart Institute was founded in 1948, and at that time it was the National Heart Institute. It's now the National Heart, Lung, and Blood Institute. So it's grown over time, and the mission has evolved over time. But the National Heart Institute was founded in 1948, and if you look carefully at this photo, you'll see Mary Lasker sitting at the head of the table. She was the chair of the founding advisory council. Most of everybody else you see in the room would be, I guess, old white men, right? But Mary Lasker was the founding chair of the advisory council back in 1948. At the same time, the Framingham Heart Study was started in 1948. And I understand there was a lot of interest among the attendees in hearing a little bit about Framingham, so I'll talk a little bit about Framingham. But the Framingham Heart Study began the same year the National Heart Institute was founded. This is not a coincidence. This is because at that point in time, there was a realization that there was a real public health problem with cardiovascular disease and heart disease. It was killing young men and women in the prime of life. And it was becoming an increasing public health problem, and the government said we need to do something about this. So they started the Framingham Heart Study, founded the National Heart Institute, same year. Fast forward only a few years to the early 1960s, and already the Framingham Heart Study had started to contribute knowledge about the causes of cardiovascular disease. So this paper, published in 1961, is the first time we can find evidence really of the concept of risk factors in the medical literature. Concept of factors of risk in the development of coronary heart disease based on 6-year follow-up of a couple of thousand individuals in Framingham, Massachusetts, a predominantly white community and essentially all-white cohort, but included men and women from the very beginning. The Institute's been interested in the health of both men and women. And this paper highlighted the important role of high blood pressure, high cholesterol, eventually cigarette smoking was added to the list of major risk factors. And based on the results from the Framingham study and other cohort studies that helped to contribute to our understanding of risk factors, a series of clinical trials have also been done over the past several decades to test approaches to try to lower those risk factors and therefore lower the risk of cardiovascular disease. So probably the biggest recent news in terms of clinical trials aimed at preventing heart disease came from the SPRINT trial. How many people have heard of SPRINT? Okay, so maybe about a third. So Sprint's not the mobile phone company, right? Not the phone company, but Sprint is Systolic Pressure Reduction Intervention Trial. That's what Sprint stands for. So the idea was if we treated blood pressure, the systolic blood pressure is the top number, right? Everybody knows what systolic blood pressure is. That's the top number. If we treated that to lower levels than were then recommended, would we get more benefit? So when the Sprint study started, the recommendations were to control systolic blood pressure down to around 140 or under. And in Sprint, the goal was to try to get that systolic blood pressure down below 120 and compare that to standard treatment of around a little under 140. And the investigators were reasonably successful. They got blood pressures down into the low 120s in one group and into the mid 130s in the other group. And this slide shows the results in terms of total mortality. So the Sprint study showed that there was a reduction in cardiovascular disease, but also a reduction in total mortality. Okay, that's something we really care about. So that on this slide you see that to prevent one death, or really to delay one death, because at the end of the day we don't prevent deaths, but to delay a death, it took treating 90 people for about 3¼ years with this more intensive blood pressure lowering regimen. And what that really amounted to was one additional blood pressure lowering drug on average. On average, there were 2 drugs used in the standard group, 3 drugs used in the intensive group. Not a really huge difference in terms of the burden on the healthcare system or the burden on an individual patient, but a tremendous impact in terms of reducing risk of cardiovascular disease and total mortality. And these studies, again, started with observational data like Framingham, showing us that blood pressure was important. So today, Framingham is 72 years strong. It's continuing to contribute to our understanding of population health. We've been able to do whole genome sequencing in the Framingham population and the offspring in the 3rd generation. There are multiple generations of Framingham residents who have been participating in a series of cohort studies over that 72-year period. And along with the genomics, we've been able to do work on transcriptomics. This is the RNA, so DNA is transcribed into RNA, and then that's gene expression. From there, we've been able to do work on the proteins that are encoded by that RNA, so we have proteomics data and metabolite data, metabolomics. We've been able to use the methods of systems biology to really get a much more in-depth understanding of normal physiology as well as pathobiology that underlies cardiovascular conditions and a whole range of other issues in the Framingham population, including cognition, which has become an increasing focus of our institute and all of NIH. And that's all with the goal of driving precision medicine, understanding better how people can be treated differently based on a more precise understanding of their condition so that we can improve health for all. You know, that what we've been doing to this point is basically treating everybody the same based on the average results from clinical trials. So lower is better for blood pressure, at least to a certain point. And we try to get everybody down to around 120, and we use usually the same drugs in everyone. In the future, we may be targeting the kind of drugs that we use to the specific genomics or transcriptomics or proteomics, the pattern that we see in different patients. Now, I've talked a little bit about Framingham, and Framingham was the first of our cohort studies. It certainly isn't the last. We now have a portfolio of cohort studies that is, I think is a pride point for the Institute. And so this slide gives you some of the logos of some of our cohort studies. Framingham started 72 years ago, but about 35 years ago, roughly, we started 3 other major cohort studies that were predominantly focused on the health of whites and blacks in the United States. That's the CARDIA study, the Cardiovascular Health Study, or CHS, and the ERIC study. About 25 years ago, we started the Jackson Heart Study, which is focused in Jackson, Mississippi on the health of African Americans. More recently, the MESA study, about 20 years ago, it's a multi-ethnic cohort that includes whites, African Americans, Hispanic Americans, and Asian Americans. The study of Latino health, exactly what it sounds like. a large cohort of Latinos from different heritages, about 16,000 if memory serves. The Strong Heart Study, which is a study of American Indian health. The Women's Health Initiative, the largest cohort study of women in the United States that we continue to nurture. And then the Life Course Study, which started with the Nurses' Health Study and now has included the offspring of many of the nurses, so that it includes the Growing Up Today study component focused on the offspring of the nurses. And the two newest studies, one so new we don't even have a logo for it yet, a lung health study that's focused on the health of millennials, especially lung health, but also cardiovascular health, living in, I think, 17 different metropolitan areas around the United States, just kicking off this year. And the rural study, also kicking off this year, that's focused on the health of young and middle-aged adults living in rural parts of the heartland where the burden of cardiovascular disease is so great. And we need to learn more about the reasons behind that great burden and what we can do, focusing on that population to improve cardiovascular health in the heartland. Across these cohort studies, the diversity of populations included is substantial. Setting aside the Women's Health Initiative and the Nurses' Health Study, because those are almost exclusively women, the proportion of men and women is about half and half across our cohort studies, and that's been true from the beginning. The race-ethnic distribution has evolved over time. Where now a little bit less than half of the population across our cohort studies is non-Hispanic white. We have, I think, good representation of Hispanics and African Americans. I think, frankly, from where I sit, I think we could do a little bit better with Asian American populations. But otherwise, I think we have a representation in our cohort studies that reflects the diversity of our country and that allows us to understand better the contributors to cardiovascular health and other conditions, heart, lung, blood, sleep, and beyond across the U.S. population. So it wasn't a coincidence that the Heart Institute and Framingham were started at about the same time, 1948. That was at a period when it was recognized that we had a major problem that was growing in the U.S. called cardiovascular disease mortality and heart disease mortality. So this slide shows the epidemic of heart disease in the United States in the last century. And this is one of the great public health success stories of the 20th century, up until a point. Okay, so if you look at this slide, you see heart disease mortality going up. About 1948, see if this works. 1948 would be about right here. People saw that things were getting bad, getting worse, and there were investments made to try to understand why and then to try to do something about it. And you can see that mortality rates peaked somewhere in the 50s and 60s and began to come down afterwards as some of the knowledge that was gained began to be implemented. And I mentioned this is one of the great success stories from a public health perspective of the 20th century. Since the peak in the late 50s, early 60s in heart disease mortality, there's been a decline of almost 70% in heart disease mortality, age-adjusted death rates in the United States, and a similar almost 80% decline in stroke mortality. This slides to about 2010, okay, so about a decade ago. That's a tremendous success story, and I think we would all agree that the investments that we've made in the National Heart Institute, National Heart, Lung, and Blood Institute, the research that's been done, the implementation of that research has contributed greatly to these declines in death rates. So Dr. Gibbons came to the NHLBI in 2012 at about the time of the results on that last slide. One of the first things that he embarked on when he got there in late 2012 was challenging the Institute to develop a new strategic vision looking forward for what we should be doing to continue to support the declining cardiovascular disease and to continue to focus on health inequities, not just cardiovascular disease, but heart, lung, blood, and sleep. And through a process that engaged thousands of scientists from around the world, this strategic vision document was developed. So a crowdsourcing approach was used, input was solicited from scientists around the world. And so this is not the Institute telling people what we think is important. This is the investigator community around the world telling each other and all of us what they think is important. It was synthesized into this document. It's available on our website as a PDF. You can download it. It's great bedtime reading. And because the Institute is no longer the National Heart Institute, but it's the National Heart, Lung, and Blood Institute, at the top level, the goals are somewhat disease agnostic. So you see the 4 goals: understand human biology, reduce human disease, advance translational research, and develop workforce and resources. None of them say heart, okay, because our mission is heart, lung, blood, and sleep. When I got to the Institute in about 2016, Dr. Gibbons charged me with developing an implementation plan for that strategic vision, a plan that would move the Division of Cardiovascular Sciences forward. You've probably heard it said, a vision without a plan is only a daydream, okay? You've probably also heard it said that a plan without vision can be a nightmare, okay? So we wanted to have a plan that put some cardiovascular framing around the strategic vision. And so we moved forward, again, re-engaging our external community, our external stakeholders, and coming up with a plan to put some cardiovascular framing around this. And we started with a mission statement, turning discovery into cardiovascular health. That was pretty easy because the NIH tagline is turning discovery into health. So we just took the word cardiovascular, put it in there, and we said that part's done. We can move on to the next things. And we challenged ourselves to think about our implementation plan broadly, to think about the public health perspective, the life course perspective, the translational spectrum from basic science to population science, and the idea of big goals, that if we were going to be talking about investing strategic funds, that we shouldn't be nibbling around the edges of issues. We should be trying as best we can for, major breakthroughs with our strategic funds. I say that because most of the money most of the money that comes out of our institute to support research goes out in the form of investigator-initiated, peer-reviewed awards. So that means great scientists around the country write their ideas up for science. They submit them. They're reviewed by other great scientists from around the country, evaluated, and kind of get ranked. And then we fund the best science defined by what their peers believe is the best science. That's where the overwhelming majority of our resources go. We have a relatively small pot of money that we put aside for strategic initiatives. And so when we use those strategic initiatives, we want to try to be pushing on places where we think we can make a real difference. So we said, well, what's the situation in the US in 2016? And when we looked, we saw evidence of stagnation in the decline in cardiovascular disease. Now, I showed you a slide just a couple of minutes ago, 70 and 80% reductions in coronary heart disease. Well, this slide, updated to 2015, shows flattening of the curve of heart disease, that's the top line, flattening in the curve of stroke. That's the third line if you start in 1975. So beginning in about 2010, progress in heart disease mortality and progress in stroke mortality in the United States has begun to stagnate. Now, more recently, there's even concern that that progress may be reversing. We may be seeing rates go back up. So this is a figure from the Wall Street Journal just a couple of weeks ago. You may have seen it, showing heart disease mortality rates going up in middle-aged adults in major metropolitan areas in the US. Very disturbing information, especially for somebody in a position that I'm in, where our goal is to try to support science to drive those rates down. At best, we're in a period of stagnation. We may be even in a period of reversal. If you look a little bit further under the hood at what's going on, ischemic heart disease, this is the kind of heart disease that causes blockages in the arteries of the heart that leads to heart attacks. Those rates seem to still be coming down, although they're not coming down as fast as they used to. I think you can see that in the top two slides. Slide on the left, that figure is shown overall and by gender. The figure on the right is shown overall and by race ethnicity. So I think you can see curves continue to come down, but flattening a bit. Heart failure, which is when the heart doesn't pump well enough to provide blood supply to the rest of the body, that's actually getting worse. It's going up. Okay, so that's a major issue. And there are profound race ethnic disparities in both of these conditions that persist to today despite efforts to try to reduce those gaps. And it's not just race, ethnicity disparities that we have in our country. We have enduring geographic disparities. This map on the right shows county-level data on cardiovascular disease mortality rates in 2014. Okay, and the red spots are where the rates are the highest. The blue spots are where the rates are the lowest. And of course, you could draw a map like this and you could say, well, are these differences important? And that's when it's important to look at the legend. So if you can see the legend, you'll see that down where the counties that are colored the darkest blue, the death rates per 100,000 population are somewhere around 100 deaths per 100,000 population. The counties where these rates are red, somewhere up around 500 per 100,000 population. 100 versus 500. This is a huge difference, five-fold difference in cardiovascular mortality rate at the county level between counties that are the healthiest and counties that are the unhealthiest. This is bigger than you'll see across many countries. If you look at countries that are high-income countries and countries that are low-income countries, this is a huge difference. Right here in the United States, we're not having to go look for high-income and low-income countries. Okay, and what that says to me and what it may say to others is that we've got major geographic differences in the US. We need to understand the reasons for those better and test interventions to try to do something about that. Major problems right here in the US. And some of you may see problems close to home, right? We've begun to call this the heartland, and the heart health of the heartland is not good. Okay, certainly not as good as it should be. So with that as background, tremendous progress, recent stagnation, enduring disparities, that informed our thinking about our strategic vision implementation plan. And we published a high-level version of that in Circulation Research about a year ago, back in February, which, again, is good bedtime reading. And these were the 6 big goals that we adopted to put cardiovascular framing on the strategic vision. We said we want to, and why these? Well, talk a little bit about them. Addressing social determinants of cardiovascular health and health inequities. That first word's really important. It was chosen carefully. It's addressing. It's not describing. It's not understanding. It's not examining. It's addressing. Because we've done a fair amount of describing, and we've done even a reasonable amount of trying to understand. What we believe we should be doing going forward is testing innovative approaches to try to address these fundamental causes of cardiovascular disease and differences in cardiovascular health. Testing interventions that may address them. Enhancing resilience, the concept that some people, despite living in a relatively poor environment or exposed to adverse conditions, do quite well. If we can understand why it is that some people are more resilient than others, we might be able to leverage that to help improve the health of others. On a very simple level, you've probably all heard someone say, my aunt smoked cigarettes until she was 90 years old, never had a problem. Died of something else, whatever, right? Automobile accident. Okay, so you've all heard these kinds of stories, someone who's very resilient to adverse exposures. Can we learn something more about that and leverage it? The concept of promoting cardiovascular health across the lifespan. We want to try to improve the cardiovascular health of our kids and support research on how to do that and how to maintain that health high throughout the lifespan. I'm going to talk a little bit about that here because the cardiovascular health of our kids is not as good as it should be. You've probably all been reading and writing about the childhood obesity epidemic, okay, and diabetes, type 2 diabetes becoming more common in kids. So, we see it as part of our mission to fund research to try to improve the cardiovascular health of our kids and maintain that as late in life as possible. And then there are 3 more disease-specific areas that we focused on. Hypertension is the leading cause of death and disability on the planet, according to the Global Burden of Disease Consortium. Now, you can say that's not such a big deal, it's just this planet, but, maybe it's important. Leading cause of death and disability on our planet. Heart failure, well, I showed you evidence earlier that heart failure is actually going up. It's the leading cause of hospitalization and cost in Medicare. And heart failure, especially the kind that we call heart failure with preserved ejection fraction, we have basically no treatment for currently. How many people know the difference between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction? I can spend just a minute on that because it could be interesting and helpful. The heart's a pump. For the pump to work well, it's got to relax and let blood in. It's got to squeeze and pump blood out. So there's basically two major forms of heart failure that we talk about. The ejection fraction is how much of the blood gets pumped out with each squeeze. So there's the type of heart failure where the pump doesn't squeeze well. So it doesn't squeeze very much blood out. Normally it should squeeze at least half the blood out with each pump, with each beat. So the heart failure with reduced ejection fraction, the heart gets big and it kind of squeezes a little bit, but it doesn't squeeze much. Okay? It still gets about the same amount of blood out because it's gotten big and it doesn't have to squeeze as much to get as much blood out. Okay? But that's a weak heart that doesn't squeeze well. And we have some pretty good therapies for that, although it's still a bad problem. The other kind of heart failure is when the heart doesn't relax well, doesn't let blood in. It still squeezes. In fact, it squeezes somewhat more than normal, so the ejection fraction might actually be a little bit higher than normal, more than 50% or 60%. Doesn't relax well, doesn't let blood in well, stiff heart. We don't have very good therapy for that. Seems to be related to obesity and diabetes. And maybe we actually know a little bit more about how to prevent that than how to treat it currently, because if we can prevent obesity and diabetes, we might be able to prevent that second form of heart failure. So when we try to study heart failure all together, all at once, which is something we've done in the past, we're mixing apples and oranges, and maybe really important to try to understand these different types of heart failure separately, which is where we're moving with heart failure. And then finally, vascular dementia. This is an issue that as a country and really as a world, we're not well prepared for. The dementia that's coming at us as the population ages and the older population grows. And so we're very interested in supporting research at how to improve cognition and maintain cognition as late in life as possible. In fact, one of the things we found in the SPRINT study was that in addition to reducing cardiovascular disease and reducing total mortality, the more intensive blood pressure treatment also reduced the development of mild cognitive impairment and dementia. Okay, that's really important because if we can help prevent dementia, then we can really make a big impact on something that's coming at us as a major public health problem that right now we're not very well prepared for. What is vascular dementia? Thank you. So dementia is a syndrome that includes a lot of different underlying causes. So you've probably heard of Alzheimer's disease, Parkinson's disease, you might have heard of frontotemporal disease. So there are several different causes of dementia. Well, it's become more well appreciated over the past decade or so that some of the changes that we see in the brains of people who have dementia are vascular related changes. They have evidence of small vessel disease in the brain, other vascular changes, vascular disease in the brain. It's not exactly the same thing as atherosclerosis in the major vessels of the rest of the body, but it does look like some of the same risk factors are related. So some of our observational studies, I mentioned Framingham, but also CHS and Eric and Cardi and Mesa and others, Jackson. Many of those same cohort studies that I showed you that big slide of have started relating cardiovascular disease risk factors to cognitive assessments and brain imaging studies in older age. And we're finding that diabetes and hypertension and cigarette smoking, not good for your brain. Maybe that is a big duh, but we now have some evidence that intervening on blood pressure from the SPRINT trial, not only is high blood pressure bad for your brain, but intervening on it and reducing blood pressure like we did in SPRINT seems to prevent or delay the development of cognitive impairment and dementia. So it may be a form of dementia that's related to vascular disease and vascular health rather than to brain cells dying, what's been called neurodegenerative processes, primary neurodegenerative processes where brain cells die for some reason. Okay, so determinants of health and social determinants. I'm going to spend a couple of minutes on that. Why are we focused on social determinants? Well, many of you have probably seen a slide kind of like this slide that looks at the determinants of health and tries to say how much is our health affected by healthcare versus genes versus behaviors versus, the environment, social and environmental factors. And in this version, and most versions you'll see are something like this, the environment and social conditions are attributed somewhere around 20% of our health, which is greater than actually what we believe to be the contribution of healthcare delivery. Okay? With most of our health being attributed to either our underlying genetics or our behaviors. But one of the things I think is really important to consider is that behaviors are often influenced or constrained by social conditions. You can think about that it's hard to eat a healthy diet if you don't have good sources of healthy food in your neighborhood, if you have to go a long way to find a store that sells healthy vegetables, if you live in what's called some people call them food deserts, but I've also heard them recently called food swamps, because it's usually people aren't living in a food desert. They're living in a food swamp where all the food that's near them is bad. Okay, fast food that's high fat, high salt, corner stores that sell food that's high fat, high salt, lots of processed foods, high sugar foods. So they're not deserts, they're swamps. It's also hard to be physically active if you live in a community that doesn't have sidewalks and doesn't have recreation centers and parks, or where there's a lot of crime and you feel it's unsafe to go out and be active in your community. So the environment can really influence our behaviors. So, when I look at this, I think social determinants are probably more than just 20%, but even if they're only 20%, it's something we need to learn how to address. Some slides that I think are interesting to think about, social determinants in the US. This slide's from a study we helped support that looks at the prevalence of hypertension, high blood pressure in the US at the county level, showing that hypertension is more common in the heartland, where heart disease is more common. That's interesting, and we know hypertension is related a lot to diet and physical activity and obesity. I grew up in North Carolina, so I know what the southern diet's like, high salt, high fat, sweet tea, so there's probably some environmental reasons that underlie this pattern of hypertension in the US. And you can say, well, it's easy. We just treat hypertension. It's easy to control. We showed you in SPRINT, we can control blood pressure down to 120. We can prevent cardiovascular disease, delay deaths. We can delay dementia. And we've been making pretty good progress on treating hypertension in the US. We started with the high blood pressure education program in 1974. We've been working on it for, almost 50 years. And we have control rates up to about 50% after about 50 years. We've gotten control rates up to about 50%. Now, it's true that the threshold has changed over time, so we're treating to lower levels. That makes control harder. But recently, we've even had a little bit of backsliding in our control of hypertension. And 50% success in control of hypertension is not great. So we need to do a little bit better job of preventing high blood pressure in the first place so that we make it a little bit easier to treat it when it exists. Smoking. So smoking is also more common in the parts of the country where heart disease is more common. That continues to this day, and there are probably some social reasons for that. But this map from the CDC's website, the darker the color of the state, the higher the prevalence of smoking. And smoking is more common in the heartland than in other parts of the country. Interestingly enough, also policies to influence or to restrict smoking in restaurants, bars, and work sites mirror this same pattern. That's probably not too surprising. In parts of the country where smoking is more common, support for clean indoor air is less strong, and so policy is not as strong. So we're interested in trying to understand at NHLBI, what are the information needs of policymakers, what research needs to be done to help policymakers come to decisions about things like clean indoor air, which there's already pretty good evidence that these policies result in reductions in heart attack rates, reductions in stroke rates. That's been shown in a variety of communities that have evaluated the impact of public smoking restrictions on hospitalization rates for heart attack and stroke. And poverty, of course, is probably the mother of all social determinants. And although this map's a little hard to see, The darker colors are where poverty is the greatest, and again, tends to correspond with where we see cardiovascular death rates being the greatest, such that in places where there's a lot of poverty, people have fewer resources to access healthy lifestyles, healthy diet, and have other healthy exposures. So what are we doing about it? We're trying to understand the interventions that may improve social determinants and improve cardiovascular health. So we recently had an initiative called Decipher, disparities elimination through coordinated interventions to prevent and control heart and lung disease risk. We are the National Heart, Lung, and Blood Institute. And if I showed you maps of lung disease in the United States, they would look almost superimposable on the maps I've shown you for cardiovascular disease and the maps I've shown you for tobacco use. Would that be a surprise? No, that wouldn't be a surprise. So we're focused on both heart and lung in this particular initiative. And the idea is to test evidence-based interventions now at the community level. Interventions that we have evidence from in kind of expert settings, test them in real communities, see if they make a difference in driving down rates of cardiovascular disease and driving up cardiovascular health and control of cardiovascular risk factors. So all the applications are in. They just came in December and should be funded soon, including maybe some of them near where you live, because we're hoping they'll be in high burden areas. I'm going to shift gears to cardiovascular health across the lifespan with a focus on our kids. Okay, so how are things going in our kids? Well, you know about the obesity epidemic, you know about diabetes being more common in kids. This is a slide prepared by the Heart Association based on data collected by the CDC that looks at kind of a stoplight scorecard on cardiovascular health metrics in kids. Have you heard of Life Simple 7? The AHA has adopted this thing called Life Simple 7, which I think is a great idea. And so there are these 7 things you need to do to live a long and healthy life with a low risk of heart disease. According to the Heart Association, it's don't smoke, stay lean, be physically active, eat a healthy diet, keep your cholesterol, blood pressure, and diabetes optimal levels without needing treatment. If you can do all 7 of those things, you know, you'll live a long and healthy life, low risk of cardiovascular disease. So how are our kids doing? Well, almost none of our kids are eating a healthy diet. Too few of our kids are getting the recommended amount of physical activity. That contributes to too many of our kids being obese or overweight. And of course, that relates to higher cholesterol and blood pressure and diabetes levels than our kids should have. Now, you might look at this and say, well, smoking's not so bad. Only 6% of our kids aged 12 to 19 are smoking. This doesn't include vaping. So if we included vaping, there'd be another quarter of these kids probably vaping. It's become a real national epidemic, and we could talk a little bit more about that in the Q&A if you'd like. So the cardiovascular health of our kids is not great, and if you add them up and say how many of these ideal metrics do our kids meet, 12 to 19-year-olds, over half of them hit 4 or fewer out of 7. Now, 4 or fewer out of 7 is not exactly a passing grade when I was in school, okay? And over half our kids are 4 or fewer out of 7. Okay, fewer than half our kids get 5 or more. That's not good, that's bad. So we are interested in funding research to try to improve that, drive those levels up of ideal cardiovascular health metrics. The concept is that today, only about half our kids, by the time they get to be 10 years old, only about half our kids are hitting 5 or more of these ideal health factors. And that continues to go down over time. I didn't show you data from adults. By the time you get to about age 50 in the US, it's under 10% of adults hit 5 or more of these factors. It's very, very few. That's the current situation. Half of our 10-year-olds, 10% of our 50-year-olds have good cardiovascular health. So we want to fund research that understands how to improve that. First of all, how to prevent the loss. I mean, even if only half our kids have good cardiovascular health, can we keep that stable? What's responsible for the continued decline in cardiovascular health from childhood into middle age? And then can we push it up? What's responsible for poor cardiovascular health by the time our kids are teenagers? Can we improve it at birth, keep it high, and beyond, drive that cardiovascular health up? That gives us a goal to pursue that in addition to just driving down cardiovascular disease mortality, this is a strategy to get there. drive up cardiovascular health metrics with an eye on the eventual elimination of cardiovascular disease. A bold idea, but one that increasingly we're talking about. And what are we doing in this area? Well, we've had several workshops over the past couple of years where we bring experts together to give us advice on the sorts of initiatives we should be thinking about. That advice also gets reported back out to the communities so that investigators who are thinking about writing their applications can be advised and informed by these reports. These reports are all on our website. If you're interested in what sorts of experts we bring together and what kind of advice they're giving each other as well as us, you can go on, you can Google NHLBI workshop and you'll get our workshop page and you'll find the workshops we've done recently and what the recommendations from those workshops are. And these are just 3 that we've done in the past couple of years focused on the topic of promoting cardiovascular health in childhood and young adults. And I think these slides are going to be made available to everybody so that you'll have this information. So just to wrap up, our focus is on supporting research that's about cardiovascular disease and cardiovascular health, and also turning that discovery into improved health at the population level. Our new initiatives that we're going to be investing in over the next 5 to 10 years won't be exclusively related to these topics, but will include a focus on these 6 topics that is guiding the implementation of our strategic vision. And with that, I'd be happy to try to answer any questions you might have or enter discussion about these topics or other things that might be on your mind. Thanks for your attention.
Okay, we have plenty of time for questions. We'll just, we just got one microphone here, but we'll pass it around and we'll start with you and this end.
Okay. Thank you for your talk, Dr. Goff. That was very interesting. And I was wondering, very in the beginning, you mentioned the millennial study. And I was wondering if you could talk a little bit more what that is about and also how sort of the heart health of that age group may have changed over the decades, starting with the 50s until now.
Well, thank you. Great question. So the 2 newest cohort studies that the Institute is starting are both starting this year. One of them is called the Rural Study, and we're recruiting individuals between the ages of 30 and 64. We're trying to come up with the money to go down to age 25, but right now that study is focused on individuals 30 to 64 living in rural areas in the heartland with the idea of trying to understand the special causes of the high heart disease burden in those populations. And the investigators have picked out counties. Some of the counties have high death rates, some of the counties have low death rates. They're all rural counties, are all in the heartland in those states. And so we hope to be able to understand how some communities that are rural and would be predicted to have poor health are doing well, others are not doing so well. And that will include some members of the millennial population. The other one, the lung health study, is focused on individuals 25 to 34. This study is also starting this year, and it's being conducted in 17 metropolitan areas around the United States in conjunction with the American Lung Association that has a network of clinical research centers in these 17 metropolitan areas. And that study is focused on understanding healthy lung aging, differences in healthy lung aging, and how, so it starts with people 25 to 34, but the expectation is that we'll be following these individuals in both studies for decades, not just for years, and so that we'll learn about some of the long-term health as it evolves. Now, by virtue of starting both these studies at the same time, we have a unique opportunity that we're leveraging, and we have the people working together so that we're doing some of the same measures in both studies. So we're looking at lung health in both studies, heart health in both studies. We're collecting information in the same way across studies in terms of behaviors, things like diet and exercise and tobacco use and vaping and social determinants and so forth. We're collecting in the same way across the 2 studies insofar as possible. For some things, it may not be practical to do them exactly the same way, but insofar as possible. That way we can also compare folks living in the rural areas and folks living in the metropolitan areas on a number of characteristics, including their cardiovascular health measures, their lung health measures, and other things of interest.
I was very interested in the slide that you had on the difference between whites and blacks in America on high blood pressure. Could we go back to that?
I think it was this one?
Yes.
Is this the one?
Right. So if you look at the America for hypertension in blacks, it seems to be less than the South area for hypertension in whites, which, we know it's a stroke belt, but I've always thought that it was predominantly driven by the African American, and it doesn't appear that that's necessarily the case throughout the entire area.
So this is another one of those examples where looking at the legend is really important. And I took this out of the paper as it was published. So, if you look at the legend, the top range for prevalence of hypertension in whites is around 57, 58%. If you look for blacks, it's around 77, 78%. So some of the areas that don't look very red for African Americans are actually pretty hot if you compare the prevalence, because the prevalence is so much higher in African Americans than in non-Hispanic whites. So the direct comparison of the colors between the two maps is misleading.
No kidding.
But what I think you see in both maps is the pattern is that the biggest problem is in the heartland, in both groups. And also I think you see to some extent in African Americans a pattern you don't see in whites, in that some of the metro areas in the region up around Michigan, Detroit, up in that area, there's also some major problems with hypertension in that part of the country and in African Americans. You don't see that to the same extent in the white population. Not sure what that's about, but anyway, and these are models, so models aren't perfect.
I see now that it on the black side, it doesn't even start. 56 and then it's 68. So
Right.
yes, of course. Okay.
Yeah.
Gotcha. Thank you for that.
Oh, you're very welcome. Sorry I didn't point that out.
Can you talk about the social determinants do you know if there are successful strategies? And it sounds like your focus is at the community level. And I'm curious if there are also, policies that should be put into place nationally that would help.
Yeah, thanks. That's great. There are some things that have been done that show some success. I'll pick out maybe a couple that are kind of intriguing. One of them because it's probably not all that practical, and the other one because I think it might actually be practical. So there was a study done that I think was called MOVE or something like that, where they actually gave people vouchers to move out of kind of low-income housing into other parts of the community, and then they tracked the success of these families over time, including the success of offspring. And there was some evidence of better health metrics, not necessarily cardiovascular health metrics, but better health metrics, because I'm not sure they measured cardiovascular health. Better educational attainment, better economic success, both of the individuals who moved and the offspring of the individuals who moved. Now, whether that's a practical thing that we can do, that would require some major social, kind of re-engineering in the U.S. Another study that's been reported is something called the Nurse-Family Partnership, and that's been going on for a couple of decades. Again, not focused on heart health, but focused on child health and maternal health, sending home visitors into the homes of first-time teen mothers is where the model started, low-income first-time teen mothers, showing that the home visitation program improved the outcomes of the mother, more likely to stay in school, finish school, have a economically sustainable situation, better parenting skills, better child health outcomes. Again, not focused on cardiovascular health, but other measures of child health, school readiness, and among the kids followed over time, fewer interactions with the criminal justice system. So, a home visitation program, something that has now been put in place by HRSA, supported by HRSA. All 50 states and I think territories have this as well. And the home visitation program is an example where social conditions have been ameliorated, right? Now, we still have the situation that we're facing today. So the question is whether there are other things that can be done, other strategies that can be tested and then put in place.
Is there anything that you think should happen nationally and national policies or anything?
Well, I'm from a research institute, and we try to stay in our swim lane. So we support research that will provide information needs that will address the information needs of policymakers. Where we can get into difficulty sometimes, and I don't want to get in that kind of difficulty here today, is when we start making policy, policy statements. So I'll probably try to avoid that if I can. I'm looking back at my media person who's saying, yeah, you're doing a good job, don't do that. Later, some other time we could talk. But that would just be me talking about my opinion, not me as a representative of NHLBI.
We have Alex, then we have Emily H., and then Marissa.
Sure. I was really surprised to see on the long-term heart disease death rates that we are actually still higher than we were 100 years ago. I mean, it looks like starting in the 20s is when it really, the 1920s is when it really ramped up. I mean, do we know what caused that? I mean, was that just smoking and diet, or were there other factors?
Oh, great question. So a lot of people have written about this, and one of the things that I find compelling when I read what people have written in this area has to do with the change from kind of chew tobacco to cigarettes that happened at about that time. R.J. Reynolds, James B. Duke, they were really path breakers, the trailblazers, if you will. And it was in the era of the Industrial Revolution in factories where they hired people to roll cigarettes and sell cigarettes pre-rolled. And that led to a big change in how tobacco was consumed from what was previously predominantly chewed tobacco or in a pipe to people buying pre-rolled cigarettes sold in a package that would fit in your shirt pocket. And then those were also made available to servicemen who went abroad and fought in World War II as part of the rations that were provided to servicemen. So, the rapid uptake in combustion tobacco products that happened at about this time is a pretty remarkable parallel that predates the rise in cardiovascular disease mortality by about a decade, which is about the timeline you would expect for the accumulation of damage to the arteries and damage to the arterial system. So it's a pretty compelling story that a lot of the increase is probably related to changes in tobacco consumption and also changes in the food supply. 100 years ago, pellagra was common in the Southeast United States. That's a nutrition deficiency syndrome where a lot of farmers were living subsistence farming in the U.S. 100 years ago, in the 1920s. So there's been rapid, big changes in the food supply. Now today you can get mangoes in Minneapolis in the middle of January, right? So major changes. And during this period of time, big changes in refrigeration, food supply, food availability.
Hi. Yeah. Sorry, my colleagues are probably going to get annoyed because I'm going to ask this question in every session that we have. But I was hoping you could talk about how the risk from air pollution relates to these risk levels that we're seeing? And particularly when you were talking about dementia earlier, I've seen some interesting studies coming out about the link between air pollution and dementia, and I'm wondering how much heart health factors into that.
Thanks. Great questions. I took that slide out. There are actually some maps that show air quality at the U.S. Might not surprise you that some of those maps of air quality in the U.S. Would look similar to some of the maps I've shown you about cardiovascular disease or lung disease in the U.S. So there's, I think, that body of evidence is really firming up that particulate matter exposure, especially some of the small particles that penetrate deeply into the lungs like PM2.5, that the level of exposure to PM2.5 is related to risk of cardiovascular disease, related to risk of pulmonary disease, hospitalizations, deaths. The question is whether, where's the threshold? And, if you look around the world, there are certainly places where the level of exposure is really, really high, and the health impact is going to be substantially greater than in most places in the U.S. these days, because air quality has improved at least through about 2015. I haven't seen much more recent data, but we've seen significant improvements in air quality in the U.S., so things have been going generally in a good direction over a period of decades. Don't know if that's persisting in more recent data, but there's certainly problems in other parts of the world where air quality is a major issue. Sub-Saharan Africa and major metropolitan areas, for example. You've probably all been reading about places in India and China with real air quality issues. Now, the extent to which this contributes to dementia, much less is known about that, but to the extent that vascular disease and vascular changes are important. These exposures increase inflammation, they activate the immune system. It's probably not good for your brain, but we don't have as strong evidence on that issue at this point.
Is it hard to Is it difficult to confirm a causal link with air pollution and heart health, seeing as like most of the poorer places that have less nutritious food available are going to be more likely to have more air pollution too?
Yeah, so you asked a really tough question there about causality, which we could probably spend a lot of time on in terms of how much evidence do you need and of what sort do you need to reach a causal conclusion, and what evidence do you need to then drive policy to try to address that thing that you've labeled as a cause. A lot of writing about that. When it's certainly harder when you have something that you can't randomize people to provide the kind of evidence that people will that everyone will agree is causal. I mean, just look at the situation with cigarette smoking and whether that's a cause of cancer or whether that's a cause of heart disease or stroke. There are a lot of debate for many decades as to whether the evidence was strong enough to come to causal conclusion. And while that debate is going on, it's challenging then to drive policy to try to improve the situation. So, with air pollution, I think it's also challenging because there will be the same kinds of debates, in part because of the influences beyond human health that are considered. And if you think about, I was in Colorado for 5 years, and fracking was a big thing. And so you would have some people saying that, well, fracking has lowered the cost of natural gas and lowered the cost of petroleum products and helped bring people out of poverty and improve their health in that way. And other people would argue that, well, fracking has, harmed health in some ways. And you get these debates that then, the policymakers have to come to some conclusion on. Our role in all this is to support the science that will generate the knowledge that then the policymakers can take and balance on the pros and cons of the different, stakeholders who come to the table around an issue like air pollution or other issues that may impact human health unfavorably in some ways, but reflect things that lead to improvements in human health in other ways.
Hi. So in the beginning of your presentation, you had a pie chart that was about the ethnicities, and nearly half you had labeled was other. And I was wondering if that's as far as you guys are taking the data, or is there anything you could tell us in terms of that population and any interesting findings?
Okay, so I'm sorry that the labeling is not very clear. That 49% is white.
Oh my gosh, thanks.
The other is the really small 0.2%.
Okay, great.
And I don't think I can't say anything about that at this point in time. But the 49% is white, 20% black, 23% Hispanic, 2% Asian, which is where I think, when I look at this, I think we could do, maybe we should be doing better there. That's an area that we're thinking about. 5% Native American or American Indian, and then 1% mixed.
Thank you.
Oh, you're very welcome. Thanks for asking the question, because the colors look similar at those two extremes.
We'll go over to Chloe and then Emily, then we'll come over this side of the room. We'll have Kate, Max, and Amanda.
Hi, so I was wondering, what stories are you not seeing in the media that you think could deserve a little bit more coverage? I think a lot of the coverage has to do with burden of disease or maybe the latest new study. But from your perspective, are there undercovered issues relating to heart health?
Well, I'm kind of curious to know what you think your readers are interested in hearing about. I think this framing of how to promote cardiovascular health is a very interesting and perhaps motivational thing. If you think about what drives behavior, what's the motivation? So there's this concept of motivational interviewing, where you try to find out from someone what their life goals are and why they might be willing to make changes in their behavior to hit a certain goal that they may be looking for. And so I think if we understood better what's motivating some folks who are finding it hard to change their behaviors, we might do a better job of providing the information that they need so that they could see that being in their best interest to make those changes. So trying to improve cardiovascular health, including especially a focus on kids, I think that's really important. Like to see more attention to promoting cardiovascular health in mothers and children. Maternal mortality is a major problem in the U.S. We rank, in the last data I saw, we're like in the mid-30s across all countries in maternal mortality. Same thing for infant mortality. Is there something that we can do to draw attention to that and to improve, support more research on how to improve maternal health and child health? Those are topics I think are really important. Obviously, there's been a lot of attention to vaping recently, and that's an area of significant interest to our institute, especially the lung division, but also the heart division. So more attention to that, I think, would be useful. Hillary?
I just add just awareness in general. There's still a large number of people who are not aware that heart disease is the leading cause of death. So we can't say it enough.
And that's especially true that, for whatever reason, it seems women in particular are unaware, and that may have something to do with the successes of some of the other advocacy groups to get their message out about the other important health concerns of women that I would not want to in any way diminish, but heart disease is a leading cause of death of women in the U.S., and most women don't know that. That's why I'm wearing this red dress pin today, by the way. This is a red dress. Heart disease in women, largely preventable. We really do believe that about 80% of the heart disease that occurs in our country could be prevented by adopting Life Simple 7, eating a healthy diet, which most of us don't do, getting enough physical activity, avoiding smoking, staying lean. If you can do those things, most people won't need blood pressure medicine or cholesterol medicine or develop diabetes. So although it says Simple 7, it's actually almost like a Simple 4. Eat a healthy diet, get enough exercise, stay lean, and don't smoke, and avoid people who do smoke. because secondhand smoke's bad for you. And get enough sleep. That's also important.
I'm wondering your vascular dementia prevention effort. How often do you think it's misdiagnosed, and how does that affect the accuracy of how we understand it, our risk for it, or just our understanding of vascular dementia in general?
Yeah, so I'm not a neurologist specialist, so I don't know that I have good data on how often it's misdiagnosed, but I will say that, dementia is a syndrome. So it's hard to know without specialized testing that can include brain imaging and other blood testing what the underlying cause of the dementia is. So when I've been talking with my counterparts at the National Institute of Neurological Disorders and Stroke and the National Institute on Aging, and we've been talking about this area of dementia and vascular dementia and other causes of dementia, there's a big effort now that's being led primarily by the National Institute of Neurological Disorders and Stroke to develop a biomarker panel that will help improve the diagnosis of the cause of dementia. They're working on that, investigators around the country working with them. We're excited about that because, things that improve the ability to diagnose the underlying cause can also help us do better studies in the future related to prevention or treatment. Right now, there aren't good treatments for most forms of dementia. And I think that's in part because we haven't refined the different subtypes of dementia well enough to be able to study them separately and try to figure out what's going to work differently in different types of dementia.
So we only have 6 minutes left. We have Kate, Max, and Amanda, so keep them fairly tight, I guess.
You mentioned, is this on? Okay. You mentioned vaping. Can you sort of draw the line for me? Is the concern that we've, all but wiped out smoking? Smoking is way less. And now that there's all these kids vaping and getting addicted to nicotine, is there a fear that we already are seeing these heart and lung diseases go up again, as you've shown us? Is there a concern that smoking will again be a thing, and that's why you're all worried about that? But
So why are we worried about vaping? So
I mean, as it relates to cardiac and lung health.
Sure. So we could connect you with folks in our lung division who could get you more information about lung health aspects, but you've probably been reading or even writing about the acute lung injury that's been described in association with vaping that the CDC's been working on. We've been collaborating with them. That looks like it may be related to some extent to some THC-containing products and maybe vitamin E acetate. You're probably all familiar with that. The concept of heating up a substance, especially an oily substance, and then inhaling it into your lungs, deep into your lungs, on the face of it, this is not a smart thing to do, right? It's not like inhaling some sort of vapor into your lungs is likely to be good for your health, right? And we know very little about some of the products, some of the things that are in these products that people are vaping. Like the vitamin E acetate story that has come out recently, the flavorings that are used. You probably know the story of popcorn lung from diacetyl in terms of microwave popcorn and people in those factories developing a severe form of lung disease. We know very little about the flavorings in these products. We know very little about the solvents that the nicotine is dissolved in. We know very little about the health effects. We do know some things that some of the cells in the lungs are affected even by vaping some of the commercially available products. Vascular reactivity has changed, so there's evidence of vascular stiffness with some of these products. There's reason to be concerned about the health effects of these products by themselves. Okay, not even putting aside the discussion about are these things better than smoking a cigarette. They're certainly different than smoking a cigarette. There's reason to be concerned about them and the health effects of vaping, independent of what we know about the health effects of cigarette smoking. And that involves both lung health, which our lung experts could tell you a lot more about. We can connect you with them, and vascular health. There are things that are harmless if you swallow them and eat them, not good to put in your lungs.
I had a similar question. I was just curious if there is anything emerging to show what vaping is doing to a person's heart. And then secondly, I wondered, is all of this data easily downloadable online?
All this, everything I've been showing is from published, which with, I think, the exception of this slide, might be the only thing that isn't published out there somewhere. But yeah, all the rest of it is published, and the references on the slide, and the slides will be made available. As I was just mentioning, there's some pretty good evidence that vaping has immediate effects on blood pressure, pulse, vascular reactivity. We don't know the long-term effects on heart health, but something that has short-term acute effects like that, one would at least have some concern about what the long-term effects might be. And you know, our cohort studies are collecting information on that. The new ones we're setting up, both the lung health study and the rural study, are also going to be collecting information, as our older cohort studies have been. So we hope to be able to provide more information on this as we go forward.
Okay. Yes, can you show the smoking laws, the slide on the smoking laws by state really quickly? I just kind of wanted to know what the standard was for that, because there was one that surprised me. Yeah, so it's smoke-free indoor air laws, and it says there was no law in Connecticut? Is that what it's saying, or am I not reading that correctly?
I believe that's what this says.
Okay, I don't think that's true.
As of June 30, 2018.
Okay, yeah, because in 2003, they passed the Connecticut Clean Indoor Air Act that did make it illegal to smoke in restaurants. And as long as it wasn't, I think, bars or taverns. I actually did look it up while you were doing your presentation, because I was surprised to see that. It would be a heck of a story in health-conscious Connecticut if they didn't have a law. I'm pretty sure that they do.
They may. This came straight from the CDC's website. So
I'm not challenging. Yeah,
no,
I was just surprised to see that. So I just where could I find more information about that for my own reference?
I would say follow up with the CDC and their Office of Smoking and Health, and see what the explanation for this is. A year or two prior to 2018, California used to also show no law, and that was because in California, a lot of the work had been done at the county level rather than the state level. And so, you know, the issue was the map made it look like California hadn't done anything, but in fact, California was pretty comprehensive at that point in time, but it had been done at the county level, not the state. So I don't know what's going on in Connecticut.
Yeah, I did get the information off of the state health website, so I don't know either.
Well, it could be an error, but
maybe there's a caveat that I'm not aware of that makes it.
yeah, thank you. Okay. Well, really appreciate your interest in our work and help in getting the message out to the public. I think if I were to kind of try to hone that message, we've had tremendous progress. We're now having some stagnation or maybe reversal, perhaps related to the obesity and diabetes epidemics. We have enduring disparities, and we're trying to support research to try to understand all this better. But even with the knowledge we have now, heart disease is largely preventable if people, you know, eat a healthy diet, get enough activity, stay lean, and don't smoke, and avoid people who do smoke. So, if, you know, the leading cause of death in our country and the world is largely preventable if we can get that information implemented. And so a lot of what we're trying to do at this point is support science on how to implement that knowledge better at the population level. So thanks for your interest in our work.